Hi, I'm Eric Cow, and I'm proud to serve on the board of directors at the Scleroderma Research Foundation. Thank you for joining us today. For our final session, we'll be covering Raynaud's and digital ulcers, biology and treatment strategies. I'm excited to introduce our speaker, Dr. Tracy Frech. Dr. Frech serves as an associate professor in rheumatology and immunology at Vanderbilt University, where she is building the Scleroderma program. Additionally, she has been the director of the Scleroderma Clinic at the University of Utah since 2007. Her research interests include the vascular aspects of autoimmune disease, primarily vascular leak and systemic sclerosis. Dr. Frech is a leader in the SRF-founded CONCA registry, where she is the current steering committee chair. Thank you, Dr. Frech.
Thank you, Dr. Cow, for that warm introduction. It is my absolute pleasure and delight to be here today, virtually speaking on Raynaud's and digital ulcers, biology essentials and current treatment paradigm. I have no relevant financial disclosures or conflicts of interest. And here are some great articles for patients who want references to really delve into the topic of capillaroscopy and assessment of Raynaud's, which I'll be presenting today. So we have three main objectives today in a brief period of time. I'd like to discuss a proper clinical approach to Raynaud's phenomenon, talk about how we can protocolize capillaroscopy as part of clinical care, and really highlight the importance of an interdisciplinary and translational approach to vascular assessment in Raynaud's phenomenon. Now, Raynaud's phenomenon is something that's important for us as a community to understand that lots of people have Raynaud's without having systemic sclerosis. About 5 to 20% of females and 4 to 14% of males will have fingers that change different colors in the cold environment or stressful situation. However, the importance of Raynaud's is it is the first symptom in most patients with systemic sclerosis. And because it's a symptom complex, which means that the symptoms really drive the severity of the assessment, we really do need patients to tell us how severe their symptoms are in order to do a good job with management. So when we rely on patient self-report for severity quantification, it's incredibly important for a patient to come and talk about how much pain they're having with their Raynaud's phenomenon, even if they're not asked about this specific scleroderma symptom. If there is a digital lesion, that always needs to be seen by a rheumatologist and importantly by wound care specialists, because treating a digital lesion before it gets severe is an important component to wellness. And then whenever you hear this term primary Raynaud's, that really probably doesn't apply to anybody who's tuned into this webinar, because primary Raynaud's means that there is no underlying pathology that's been demonstrated, meaning there has not been a diagnosis of systemic sclerosis. So some of approach to Raynaud's means understanding the terminology. So how do we ask about Raynaud's and its severity? We usually want to make sure that patients have these symptoms when they're exposed to cold or stress. Remember, 2 color changes, white and blue, are sufficient for a diagnosis of Raynaud's phenomenon. But there's some real important clues. It should be bilateral, and it can occur in the toes, nose, nipples, and ears. And most importantly, if you have a good picture of your Raynaud's phenomenon, you can show it to your provider, and that can give your provider an idea how well their treatment approach is going. Now, in general, it should be bilateral. So if it's on one side of the hand and it's positional, there is always concern that you may also have thoracic outlet syndrome. And this is where the vessels are pressed underneath the clavicles. And if it's due mostly to scaling muscle tightness, some physical therapy can be helpful. And this, of course, is something that's important to diagnose because it won't respond to your traditional medications for Raynaud's. You also want to be aware if you've had a significant exposure to vibratory tools or frostbite. This type of Raynaud's generally doesn't get better with our medications, but the good news is if you remove the trigger, it oftentimes will stay static or will not get worse. If you're using tobacco or stimulants such as ADHD medications, this certainly can make your Raynaud's phenomenon worse and really highlights the importance of stopping those medications because capillaroscopy will improve. If you have taking certain medications like beta blockers or certain medications like methotrexate for migraine management, those certainly can make your Raynaud's worse. So one of the first approaches to treating Raynaud's is to review your medication list and make sure we're not doing an error in managing a healthcare condition that would perhaps make your symptoms worse and contribute to ulcer formation. And then hypothyroidism, so low thyroid and carpal tunnel syndrome, can make the symptoms a lot more painful. So making sure that if you have hypothyroidism, that your TSH has been checked, or you have carpal tunnel, that you're not a candidate for splinting or surgery can be an important component of making sure that your Raynaud's phenomenon or overlap condition is well treated. So why do we care so much, and why should we assess this with capillaroscopy? So the reason is the microvessels at the base of your nail fold are incredibly helpful for us understanding how severe the Raynaud's is, as well as it can help us make a diagnosis of scleroderma. And in fact, it's been shown that patients that have scleroderma pattern on capillaroscopy, even if they don't have any thick skin yet, and if they have a scleroderma-specific antibody, there is a high likelihood that they will transition to a definite diagnosis of systemic sclerosis. And as you know, we tend to think of this in terms of how much skin involvement there is. Whereas if you have Raynaud's phenomenon with normal capillaroscopy and no systemic sclerosis-specific autoantibodies, there is a much lower transition rate to systemic sclerosis. So just looking at the fingers can be incredibly instructive. And in particular, family members that have Raynaud's phenomenon don't necessarily have systemic sclerosis, but should be assessed if they have a family member with scleroderma and they have personal Raynaud's with this procedure to kind of help move forward with a diagnosis. So how can capillaroscopy be done? There's lots of different devices. Everyone has a smartphone, and that at no cost can allow you to zoom in up to 60 times magnification at the base of the nail fold and make the call whether the capillary is normal versus abnormal. It doesn't require any formal training, and we have done or tried to integrate this into referral processes to make sure we get patients that have Raynaud's and abnormal capillaries into clinic quicker. But there's a lot of really inexpensive devices, $30, that can give us quite a bit of information, as well as the costs of the USB microscope, which allows us to really have very good quality images and to take a look and make a diagnosis. So the gold standard remains nail fold video microscopy, and there's a formal microcirculation course that allows you to get certified in this procedure. And so this look at the capillary, while it can be quite easy, is important to have someone who's using it routinely in clinical practice to know what they're looking for. So just very briefly, I want to go over what are we looking for. We're looking at that last row of capillaries, and what the measurement or a giant capillary in a scleroderma pattern means that apical diameter is increased greater than 50 micrometers. You can have some slight dilations that would need to be followed, and that's shown in panel C there. Anything over 20 micrometers is something that we would want to make sure that we take a look at with more detail, because that's concerning that Raynaud's phenomenon is related to an underlying vasculopathy or abnormal vasculature. The next step we do is we count in the 1 millimeter mark. And we're counting that last row of capillaries to make sure that we have 7 or more capillaries present. Dropout is really important, because if you have significant dropout, it has been shown that is associated with a digital ulcer. So we want to identify that risk. And then this is where the trickiest part comes in. You're looking at the shape of the capillary, and it's, to make it quite simple, if it's convex or concave is how we're going to determine normal versus abnormal. Concave is normal, convex is abnormal, and lots of different abnormal shapes are shown here. And that again can go with regrowth of vessels if someone has had longstanding scleroderma. And this is, while it's termed a late pattern, it can sometimes be a good thing if you see it in the place of a previous area of dropout. So our goal, of course, is to treat Raynaud's so that we're keeping the nail folds healthy and happy. So just some very quick basics. If your provider is going to do this, they usually will use an immersion oil. They put that on the base of the nail fold that allows the stratum corneum to be imaged, and so that you can look at the actual quality of those capillaries. And this, if you don't have the immersion oil available in clinic, you can sometimes use a KY jelly or some other substance just to get the dryness away at that base of the nail fold. Now, optical magnification, the standard is 200 times, but we've already talked about you can get some good magnifications just with your iPhone. And then the reason these different devices are so costly is as you add a different light source to the device, it adds the cost. And the light sources become particularly more important in pigmented skin. So I show you here kind of the standard cheap devices that don't have the spectrum of color rendering that ideally we'd like with that gold standard device. And then very lastly, we've been really working closely with different companies on getting artificial intelligence software interpretations so that we can really get these devices in the hands of your providers. And this would be the typical components of a report if it was done in the clinic. It tells you a number for density, whether there's enlargement, whether there's any capillary deformities. Again, that gets at the concave versus convex. And then I highlight while microhemorrhages are kind of a standard capillaroscopy abnormality, as we move into the world of AI, this is actually probably going to be dropped as a parameter. And the reason is AI oftentimes calls dirt as microhemorrhages. So it is a little bit of a limitation of these really integrated AI reports. But if you go into clinic and you get a capillaroscopy performed, these metrics over time can help you know whether your Raynaud's is being adequately treated. So as we shift to the second part of the talk, I hope I've convinced you that looking at the nail fold, even with cheap devices, is effective and an inexpensive screening tool. I've had lots of patients who like to track their own capillaries over time, and I think that's just fine. So the gold standard is this nail fold video capillaroscopy device, and that does require certification in order to use it, both for research purposes as well as integrative decision-making with escalation of therapeutics. And we're really working to understand the role of AI and serial use, but practice makes perfect, and we really encourage all of our providers to really use this device to assess your Raynaud's. Well, you're going to say in the second part of the talk, okay, you've convinced me that we should be looking at the blood vessels. That's important, but what does it matter? Because it's very difficult to get the necessary therapeutics that we need to treat Raynaud's and prevent and treat digital ulcers. So just a word on that. When you look at guideline-based care, there's in general kind of 4 categories of medications. I show in these different lines access to therapeutics by formularies of the different countries, and you'll see that there are no lines coming from the FDA because there's no FDA-approved drug specific for Raynaud's phenomenon. And that is somewhat frustrating for our patients being treated in the United States because oftentimes that leads to out-of-pocket pay for access to these therapies. So I'm going to spend a moment to go through kind of how do we apply guideline-based practice in the United States when we don't have access to the therapeutics quite easily, as in the other global places where the guidelines are made in conjunction with U.S. physicians. And I think this is a nice transition as well because it really highlights the very importance of using capillaroscopy and getting real good, robust data so that we can move the field forward to get therapeutics for our patients. So this is sort of the classic guidelines that patients oftentimes bring in, and I have some red boxes on how they should be interpreted in the U.S., and I've summarized them down here. So firstly, when we look at the guidelines, it talks about calcium channel blockers, and that's usually oral nifedipine because that's what the research was done on. However, any patient would tell you if you start with really high dose nifedipine, you get lots of lower extremity edema and really bad reflux. And so what I do in my clinical practice is I start with amlodipine, which is a calcium channel blocker at a 2.5 milligram dose, and I up titrate that slowly, and I oftentimes will have my patient in compression hose to allow that up titration. I also educate the patient on an exacerbation of reflux so that we can be cognizant or aware that that's a side effect of this medication they should watch for. I think it's in every patient's best interest to get a wedge pillow and really protect their esophagus, particularly if they're up titrating calcium channel blockers. A word on prostacyclin analogs, that in the red box is the intravenous iloprost. Those medications are readily available in the UK and are have lots of good data. So you've been online and you said, I want this IV iloprost, but they're off-label for Raynaud's and digital ulcers. Therefore, they require a prior authorization. Why this is so important to a patient is if you are going in for an IV iloprost or epoprostenol in the inpatient setting, if the hospital has not approved that medication and your insurance company does not approve it and it's given in the ICU setting, this can accumulate a lot of cost for you. So before you get guideline-based care, it's really important that all the proper authorizations have been done so you don't get this expensive bill at the end of this treatment. And then bosentan in a box is the only endothelial receptor antagonist that appears in the guidelines. And that's a tricky medication because it usually is managed by the pulmonary hypertension specialist. And so oftentimes this medication also requires prior authorization and is oftentimes not used in the inpatient setting. So it really gets the importance of a patient understanding what they're being prescribed, how much it costs, and whether the prior authorizations have been done. I point out two other extra cheats. The first is digital Botox has not been included in these guidelines. It can be incredibly effective for pain management. And so if you have a digital ulcer, it's worth asking your provider. It can be done in the offices of dermatologists or plastic surgeons. And we've did a training session this last summer with the Concord investigators on digital Botox to try to get this more in our early registry as being something that we can capture its effect. My very last consideration here is if your insurance company has not approved a phosphodiesterase inhibitor, that's your sildenafil or your tadalafil. Just remember those are now quite cheap because they are off their patents, and you can just put a GoodRx application on your phone, and you don't need to go through your insurance company and can go off this application to get the drug for about $14. And I strongly encourage you to do that if you're having a digital ulcer and you need access to the medication quickly. A 2-week, month delay in trying to get access to medication is not in your best interest. So the kind of key as we move the field forward, and I encourage you to participate in research registries, is we're trying to get the answer to 3 cardinal questions to do evidence-based approach to Raynaud's and digital ulcers in the United States. The first is we really want to understand study length for clinical trials. One of the reasons we don't have access to these therapies is they were secondary outcomes in other trials in a year-long duration. And you can imagine that if you're going to really study Raynaud's and digital ulcers, we really should tie those trials only to winter months. So we're doing a better job at that now. We also are doing a better job defining endpoints that get at the impact of Raynaud's on a patient's quality of life in the occurrence of digital ulcers, capturing these constructs of feel, function, survival, and those terms are critically important for the FDA to approve drugs. And so not using surrogate outcomes, but instead, so like capillaroscopy, but using that to maybe enrich trials for digital ulcers, trying to get selection criteria of patients that have dropout on capillaroscopy and seeing how quick we can grow new blood vessels in those areas. It's sort of novel approaches to how we now can, in the United States, really work together to get drugs for our patients. But I want to just very briefly in the last few minutes to kind of review the critical importance of Raynaud's in a diagnosis of scleroderma. While we use the term scleroderma, which of course is Greek for hard skin, what really defines systemic scleroderma from localized or skin-only scleroderma is this presence of Raynaud's. And regardless of your skin involvement, whether you're in panel A and you have no skin involvement, or G and you have diffuse skin involvement, or whether you have atypical skin involvement that's shown in the panel B, a changing skin pattern in C, or sort of subtle differences in D, E, and F, I'd really highlight the one unifying presence of Raynaud's phenomenon with an ANA, with a scleroderma-specific autoantibody, really moves you into an area of a rheumatologist being able to take good care of you. And the first kind of point I like to make is that early disease duration, so 18 months disease duration or less, is really where a lot of the focus of clinical trials work is. But when we're talking about Raynaud's, it occurs throughout your disease duration. So it really is important for us to approach this disease of your immune system dysregulation, vascular abnormality captured here as Raynaud's phenomenon and resultant fibrosis in registry-based practice. And in particular, what we've really tried to do is get patients really, really early in disease because that's going to make the biggest impact. So patients with Raynaud's, puffy hands, abnormal capillaroscopy, and a scleroderma-specific serology meet the criteria for very early scleroderma. However, the immune system in this early stage is very different. So shown in this graph are different patients looking at their different markers of their immune system. And you can see if we compare one patient to another that look clinically very similar, there is a patient BW with no inflammatory signals, so those immunosuppressants really wouldn't perhaps work well for that patient, whereas patient AB that has lots of different inflammatory pathways elevated, immunosuppressants of any variety might help this patient. That really kind of makes us all focus on the cardinal question here is how should a rheumatologist best manage scleroderma? And I hope to make the pitch to all of you, it is all based on a good vascular plan. So whether you have less than 18 months disease duration, it's really taking off, so people are trying lots of different therapies, or 20 years disease duration, the vascular-based plan is important for all patients. And I'll convince you that hopefully in the next few slides, based on my own personal research program. So we did a lot of work in my early phases looking at families of risk. So if genetic risk factors are putting you at risk for systemic sclerosis, what parts of a disease defined by vasculopathy, autoimmunity, and fibrosis is important? And in fact, when we looked at the Utah population database, which links medical records to pedigrees, and we compare families that have probands, shown there in black, of scleroderma, and we compare those to families without scleroderma, what we found when we looked at Raynaud's, other autoimmune diagnoses, and interstitial lung disease, that far and away the most important genetic risk factor was likely Raynaud's phenomenon. So we then took that concept of, well, if Raynaud's is most important genetically speaking, why don't we take skin biopsies from patients that have Raynaud's phenomenon or systemic sclerosis, and take those patients and look under a microscope and look what's different in the blood vessels. And so when we did this, we were able to see that scleroderma patients have endothelial cells or blood vessels that look like they're not so happy. So we then said, okay, if we look at those Raynaud's patients and we look at the capillaroscopy and we look at the sublingual capillaroscopy, we found regardless if a patient had imaging of their fingers and their tongue, it affected all types of vessels, no matter the size, and that dropout in the fingers also showed dropout of vessels underneath the tongue. This really spoke to the importance of understanding the vasculature as part of a scleroderma patient's plan. And so we did a series of different human subject experiments to try to really understand how can I then take information from a research setting and implement that into clinical practice. And so when we looked at patients' flow meter dilation, we looked at the blood flow through their vessels. We then occlude the cuff and then release it and see how does that blood vessel relate to that lack of blood flow by response. We found that patients that shown in here in the red that had the lowest forearm blood flow were not able to respond by vasodilating to that cuff occlusion. Patients in red developed digital ulcers. Patients in green had digital pits, so they could heal those ulcers, but they weren't as robust as the patients in yellow who acted more like healthy controls. And you might say, okay, well, what does this tell us? If you do a cross-sectional look at the patients with Raynaud's, with no digital lesions, and then the patients with digital lesions, we saw some really important things here shown in red boxes. The first is that patients at baseline that had low baseline flow to their fingers get ulcers. So what does that mean to you? Every patient with systemic sclerosis should be getting good blood flow to their fingers. So even though rheumatologists tend to think of immunosuppression and trying to treat the immune system, actually your rheumatologist also needs to really be thinking through, how do I get good flow to my patient's fingers to prevent digital ulcers? The other thing that was quite interesting is it was the shear rate, it was the response to cuff occlusion, that luminal side of the blood vessel that was really important. And why do we care? Because most of our blood vessels medications target the smooth muscles, so they relax the smooth muscle that's surrounding that endothelial cell, but maybe it's the blood vessel lining cell that's the most important here. So in order to try to prevent digital ulcers, we really have to understand, how can we make our patients' blood vessels respond better to shear rate? And so this is important. It was an important experiment that looked at single limb exercise. And even at baseline, we showed patients with scleroderma had a higher level oxidative stress and an attenuated antioxidant capacity in their blood at baseline. So that we now have discovered that the blood vessels are sort of swollen in scleroderma. They don't work so well. And the question is, well, is that because there's a lot of oxidative stress? Should we be doing a better job modifying that? And we also, with this hand or single limb exercise or hand grip experiment, actually showed we could get our scleroderma patients to become more like healthy controls by just exercise in itself. So taking all this together, we say if you have a dysfunctional endothelium or blood vessel lining cell, and that's responsive to exercise, really took that to mean we better get our patients using occupational therapy or really religiously using hand exercises to improve blood flow. And if you do this, you can improve blood flow to your hand, irrespective of whether you're on blood vessel medications. And then we did a small physiologic experiment looking to see can we address oxidative stress in the setting of Raynaud's management. And this looked at 12 different patients, looking at that same experiment where we occlude the cuff and then we give a medication and see if we can improve blood flow. And these patients, this is a different mechanism than if we were giving vasodilators. And then we did this also with that hand grip experiment. So in these 25 different scleroderma patients and doing 2 different experimental conditions, really showed that endothelial stress is something very much probably present in scleroderma, but also something amenable to treatment to improve vasodilatory capacity. And then very lastly, as we conclude, how do we best model this? How do we do, so our goal, I always say the holy grail, is we want to prevent ischemia or reperfusion injury, having a process where autoimmunity is activated because those blood vessels are unhappy. And if this happens over time and it causes cell death or dropout in these capillaries, how do we disrupt this cycle? How do we do a better job making sure our patients are on the right therapeutics to prevent ischemia and reperfusion injury? And so we've done some work looking at taking patients that are healthy versus scleroderma patients, blood cells. We reprogram those into those endothelial cells, and then we can study them under different experimental conditions. And when we do that just at baseline, before any experiments are done, we see that those cells that are reprogrammed from our scleroderma blood cells, those have higher levels of oxidative gene expression. That really means that oxidative stress is critically important. Well, why is that so important to you? How can you mitigate oxidative stress? Healthy diet and exercise are free to all of us and can really have an impact in mitigating oxidative stress. So that's really important for us to understand, just modification at that baseline. We also did some more advanced cellular experiments measuring vascular leak. And what we found is that we can, in our scleroderma patients, we can really model quite nicely what blood vessels do under stress conditions. So here's just a baseline. We see that a scleroderma blood vessels are more leaky. And when we wound them, they move faster so that these endothelial cells are not super happy. but when they're damaged or they're angered, they work even worse. They have an impaired barrier function, making immune cells migrate faster, and they don't respond to injury so well. So in conclusion, you'd say, okay, you did a lot of scientific talking, but that's why I love the Scleroderma Research Foundation, is they don't just give you information on vasodilators or why you should take them, but they always want the cutting edge science to say, where should we go now? So if the endothelial cells in scleroderma just don't handle oxidative stress well, how do we integrate that into your clinical care? Well, your rheumatologist should be really encouraging you to exercise. We've already covered oxidative stress can be mitigated by exercise, and that exercise should involve hand grip strength and movement. For pulmonary, if you qualify for pulmonary rehabilitation because you have any amount of interstitial lung disease, you should be exercising, asking for those referrals. I'm not big in taking drugs that aren't studied and FDA approved. So I think oxidative stress is best mitigated by a healthy diet. Meeting with a nutritionist and doing it the natural way is better than taking antioxidant supplements. We just don't know how well those drugs are absorbed by your GI tract and delivered to your fingers. And then wound care, occupational therapy, and social work, all really important components of keeping your hand healthy and well and getting those ulcers healed. But the key to discovery and the key to move beyond just what I told you is participation in registries. And so the SRF is the sponsor of the Collaborative National Quality Efficacy Registry, which really brought individual clinical programs of excellence into a collaborative research program. And we really have moved beyond just early diagnosis to this kind of key central area. We are really determined to prevent disease progression. And the way we do that is getting lots of patients into cohorts and studying them with standard of care. And we integrate patient-reported outcomes and movement captured to really understand how do we do this best. And we're doing a big move to get capillaroscopy integrated into this registry. So in summary, I hope I've convinced you that Raynaud's phenomenon is an important part of your disease. And it requires a screening nail fold capillaroscopy evaluation for diagnosis, but really trying to make this a part of the standard of care for serial use so that we can understand what your blood vessels are doing in response to immunomodulators as well as vasodilators. I hope I've really shown you the importance of clinical findings that drive vasculopathy research so that we can really change management. The reason we have no FDA-approved therapies is the research trials were not done well, and the Scleroderma Research Foundation is really invested in this registry to allow us to do it better. And a multidisciplinary collaboration is critical for patient care. I really highlight that the gastroenterologist, the pulmonologist, occupational therapist, wound care specialists, these are really critical members of my personal team here at Vanderbilt so that we can do a really good job of taking care of your hands as well as multi-organ system disease. And with that, I'll conclude. I want to thank the scleroderma patients that participated in all the experiments, my funding sources for over the years, and my international collaborators that have that came to Nashville last July to learn a lot of these techniques and tools so that we can change the field. And with that, I'm happy to take any questions.
Hello, everyone, and thank you, Dr. Frech. That was an excellent talk for all of us to hear. And hello again, everyone. I'm Sharon Doby, and I'm honored to serve on the board of directors of the Scleroderma Research Foundation. My connection with them is I'm a retired physician and faculty at the University of Washington, and I have a son who had scleroderma. And so we got involved, and I ultimately joined the board. So let's just dive into our first question. We have a number of them. One was, what's a way to keep ulcers from getting infected? Digital ulcers.
That is a fantastic question and an important one. One of the key things is actually seeing an occupational therapist up front. There's a lot of adaptive equipment that can help keep the ulcers clean and protected, particularly if you need to cook or doing daily self-hygiene. You want to keep that ulcer bed clean and protected. There are over-the-counter and things you can buy over the internet to protect the wound, but I really strongly encourage guidance from an occupational occupational therapy, because sometimes you need to keep the wound dry in order to keep it from getting infected, and other times moisture is helpful if there's a lot of dryness and cracking around the wound. So I think one of the key preventative measures is getting expert advice up front.
What about if it's on your foot?
Another great question, because getting the proper balance of moisture imperative for prevention of infection. And so keeping it exposed, it can be dangerous if you're out walking around with dirt in a dirty environment. However, if you're at home, keep unwrapping it and keeping it open to air can help dry it out. So, the real key with ulcerations is constant vigilance to keep the area clean, making sure the right amount of balance or moisture is there, and then getting the wound looked at regularly, not only by yourself, but also by a healthcare professional, because sometimes, particularly in the feet, you can't get a very good look at it. And so having someone clean the wound and take an in-depth probe of it, the wound can be very helpful. I would also put a plug-in if it's on the lower extremity for podiatry or nail care, because oftentimes they can occur if the nail is growing into the skin. So proactive approach of getting good nail care can be important.
Great, thank you. What about, you went over the criteria for diagnosing Raynaud's, but one respondent or question said her fingers get painful and then turn bright red. And I guess initially they said, no, this isn't scleroderma. She did have an elevated ANA and centromere. But she said they burn. Would this be considered Raynaud's? Do they have to turn white?
No, so that's a very good question. You can have biphasic color change. It doesn't have to be the classic triphasic, and you can qualify. But what this really sounds like is erythromelalgia. So if it's red and hot and it's a neuropathic response, that is actually different than Raynaud's phenomenon. The kind of key things for Raynaud's are stress and cold temperature trigger it. So if instead it's where they get kind of flushed red or hot, that sometimes can be in reactions to certain medications or due to underlying conditions. And it is similar in the sense that there's a neuropathic pain, but it's different in that it's not driven by the microvasculature. It's more of a nerve-mediated pain. And so the best way to have that evaluated, I do believe, is nail fold capillaroscopy. And erythromelalgia, that should be normal. And again, with the erythromelalgia, where it's that kind of red, blanching, hot feeling, oftentimes neurologies can be useful in giving neuropathic medications and ruling out things that cause it.
Thank you. So what kind of doctors should I see to diagnose Raynaud's? That's another question.
Another great question, because ideally we're doing a lot of outreach, and I'll put a plug in for the Scleroderma Research Foundation, who's really been vigilant in this area. We want to educate primary care providers to take a look at the nail folds. However, right now, really the skill set lives in the realm of rheumatology. So particularly if someone has Raynaud's and a digital pit or a lesion on the finger, then seeing a rheumatologist and having that assessment. Now, a lot of the community rheumatologists don't have capillaroscopy available, so you may need to go to a Scleroderma Center of Excellence in order to have the formal look. There's training courses available. They're done in Europe currently. Actually, the training course is this weekend in Spain, and there'll be U.S. investigators that go and get trained and certified in the procedure. And so most Scleroderma centers will have one of the experts on their team skilled in this assessment.
Could you clarify what you mean by a lesion?
Yeah, great question. So lesion can be a pit, and that is a divot in the skin. You've had a previous ulcer that's healed, but there's an indentation in the skin. So you don't have an active ulcer, but scarring or evidence of a previous ulcer. An ulcer would be a lesion. And then also sometimes telangiectasias that are on the finger, I consider something that I would pay attention to in the setting of Raynaud's as evidence of systemic sclerosis. And then digital fissuring or cracking can be a lesion. And so looking at the health of the skin and any marks on the skin in the setting of having Raynaud's becomes an important part of the physical examination.
Another person says, I have Raynaud's, but haven't had problems with digital ulcers, but all my nails have now grown into my skin and are brittle and weak. My rheumatologist has never mentioned any sort of help for this. I wonder what I should do.
Yeah, no, another really good question. A lot of times particularly brittle nails, can be nutritional. So one thing I would say is important is making sure that your nutrition is adequate. Oftentimes they've changed the name from Central Silver to Centrum 50 Plus. So taking a multivitamin can be helpful. And again, anyone will do, but the Centrum 50 Plus will have sort of micronutrient needs that will help nail health. Now, as far as growing into the skin, that's really where I do work with occupational therapy and the wound care center to make sure that the nail health is adequate. So if there's contractures, the nails can grow and puncture the skin. You certainly don't want that to happen. So you want to make sure that you're getting nail care regularly and preventatively. Now, as far as whether you're at risk for an ulcer, so you've never had an ulcer, but you may be at risk, that's where the capillaroscopy is really helpful. If you take a look and there's no dropout, I would be less worried as a clinician that there is risk of a digital ulcer. However, sometimes when you look at the nail fold capillary and there's not a lot of capillaries there, that's really where I'll push my vasodilators. And patients will say when you push the vasodilators, the nail health improves. So there's a correlation to getting good blood flow, good nutrients, and digital ulcer prevention.
Do you use nitro paste when they're with ulcers or, with ulcers?
Yeah, I do use nitro paste, but in a couple of certain settings. The first is just remember they cannot be used with phosphodiesterase inhibitors such as sildenafil or tadalafil. And so, or Revatio Adcirc, I'll use both names. And the reason is that puts you at risk for fainting or passing out. And so it's really important if you are using the nitrogel just to make sure there's no interaction. The other thing I caution people, you're putting it in the web of the finger, you're trying to get good blood flow to the digit that you're providing it. And if you use too much of the nitro paste, it's similar if you're having a heart attack, you place it on your chest, you can get a flushing and a headache. So you want to use it sort of sparingly on the digits that require it. It is a decent medication to consider if you don't have a lot of blood pressure to work with because it is just working locally. And so if someone has really low blood pressure, nitro paste and Prozac family or SSRI families of medications are sort of the limited choices you have. So I do use it. It does have a role, but I certainly like the phosphodiesterase inhibitors a lot more. So I use it more sparingly.
So there was a question earlier in the day of a person with juvenile onset at 8 is now 18, but has never had Raynaud's and wondered what's the likelihood that she'll now get Raynaud's.
No, that is a really good question, and that I'll put a plug in again for the Scleroderma Research Foundation, these registries that we do or we collect data to answer questions better. Because the short answer is we don't know. You will read in textbooks that usually during the course of systemic sclerosis, close to 100% of patients will have Raynaud's phenomenon. However, if there is a juvenile onset and it is in remission and there's no evidence of Raynaud's phenomenon, the capillaries are totally normal, I personally would be very surprised if that symptom then started if everything else is stable. Tends to be earlier in the disease course rather than later. But again, that's where the nail fold capillaroscopy would really help you. It's entirely possible that when you looked at the nail fold capillaroscopy, it wasn't totally normal. And that would mean perhaps there was subclinical or a non-severe Raynaud's phenomenon of vasospasm as a part of that. And the fibrosis or the calcinosis was far more notable by the patient, so the Raynaud's wasn't as noticed as much as in other cases.
Great, thank you. Can you talk about caffeine in Raynaud's?
Yeah, and this is always tricky because so the behavioral recommendations do include reducing caffeine. You will have some patients, however, that says if they have a little bit of caffeine, it seems to help them. I think it really gets to the principle of vasodilatation. So any stimulant in too high of a dose, and that includes like ADHD medications, act like a little whip to the blood vessel, and so it spasms them and makes it worse. Though, however, patients will say if they enjoy a little bit of caffeine and it improves their appetite and they're eating more and they're drinking warm liquids, that they don't personally notice an effect of caffeine. So for caffeine, I think it's a very personal sort of interaction that needs to be monitored. The teaching is that it can make Raynaud's worse. So I think people should be aware and sensitive to it. But I also think that sometimes our bodies don't read the textbook. So if you absolutely love a little bit of caffeine and it doesn't seem to affect your Raynaud's, I would never take it away from you.
Great. So we're about out of time, but how about talking a little bit about, you mentioned suppos, but when should they be used, and what's your position or your thoughts about gloves?
Yeah, no, great question. So I love having everyone see an occupational therapy for compression gloves. And I think that's an important part of prevention. There are certain types of gloves that we study and research. I can't tell you brand specific, but I think the key is if there's puffiness in your hands and it's uncomfortable, getting that puffiness out is a really important management strategy. And again, the other thing is the protective gear you can wear. You don't want things too tight or that can impede blood flow. So really working with an occupational therapist on the front end for prevention can be really useful.
Great. Thank you. Well, before we close, I want to thank you very much. And this brings us to the end of our session. And thank you for sharing your time and your expertise with us today. Before we close, please take a few minutes. This is to everyone that's participating, to complete a post-event survey. There's going to be a little short video right after that, but then a link will pop up as soon as we wrap. And your feedback really matters to our foundation. It really informs what we might do next year for the same forum and the kinds of topics we'll present. So please do respond. And thank you. You'll be entered in a prize drawing right after the end and receive a swag bag. So thank you so much for watching, and we'll leave now.
Thank you so much.
Yeah, thank you.
And that brings us to the end of our program. Thank you all so much for being here. We're truly honored and energized to have had people from the scleroderma community from around the world join us today to learn and engage together. I'd like to extend my heartfelt thanks to all of our presenters, to the SRF staff and board of directors, and to our generous industry sponsors, including Boehringer Ingelheim, Johnson & Johnson, Bristol Myers Squibb, Merck, Novartis, A-Tier, and Zura Bio. Your collective support and partnership are what made today's Patient Forum possible. At the Scleroderma Research Foundation, we've had a clear vision and a singular focus since day one: to fund and facilitate research that will lead us to a cure. It's at the heart of everything we do. But we know we can't get there alone. It takes a strong, collaborative community of scientists, clinicians, patients, donors, advocates, and friends. Together, we will end scleroderma. Thanks again for joining us, and have a great rest of your day.